Welcome everyone. This is Patricia from the International Hospital Federation. I hope you're all safe and well, and thank you very much for joining us today. We are hosting this COVID-19 webinar and live Q&A series to share experiences, good practices, insights, and recommendations from our members and other organizations across the globe. The series has been created with healthcare providers for healthcare providers, including decision makers and those involved in managing COVID-19. We hope the lessons you take away from this webinar will help you in facing the crisis and beyond. I would now like to introduce the moderator of this webinar, IHF CEO, Eric de Rudenbeck. Eric?
Thank you, Patricia, and welcome to all participants. Facing COVID has been and still is a challenge in many countries, not to say all the countries around the world, but each of them have faced the situation in different ways. As we have heard in previous webinars, the country that previously had epidemic shocks had put in place preparedness plans that were activated quite early when the epidemics was on the outset. While countries that did not face such a recent epidemics were much more in a responsiveness mode. And for these countries, we have seen that in most cases, the national health authorities have provided guidance, but facilities have organized themselves with quite a lot of autonomy. So there is always a trade-off between the interest of having a system that is centralized and piloted, that gets all the latest information and they can rapidly disseminate latest advancement, versus a system that gives locally to each player the responsibility to innovate, find solutions to the challenges they face in their local specific context. We have heard quite a good number of country experience where responsiveness was driven by local conditions and local autonomy. Today, we'll go to Dubai to hear a system that works more under a command and control center, and we'll learn the challenges and the successes of such a system. Let me introduce you our today's speaker, Professor Essa Kazim. Professor Kazim is Associate Professor in Surgery in Mohammed bin Rashid University in Dubai, UAE. He has graduated medical school in 1974, underwent urological training in London, and has been working in the healthcare sector in Dubai for over 40 years. Dr. Kazim brings a very rich experience in the healthcare sector administration because he has served as medical director at Dubai Hospital, the larger public hospital in Dubai, Associate Director General for Medical Affairs and Chief Executive Officer for the Health Policy and Strategy sector at Dubai Health Authority. He supervised there the formulation of the strategic plan for the health sector. He has been instrumental in the Dubai healthcare reform, where the Department of Health and Medical Services became the Dubai Health Authority. By the way, it's a long-lasting IHF member, and I have to acknowledge that the DHA has hosted in 2011 the World Hospital Congress and will be hosting it again next year. Professor Kazim led the team to develop healthcare regulation for Dubai, and he's been still a consultant medical advisor to the DG of Dubai Health Authority, providing advices on organizational and patient care issues. Professor Kazim, the floor is yours to share the experience from Dubai.
Thank you, Eric, and thank you for having me on this webinar. Ladies and gentlemen, good morning or good afternoon, depending upon which part of the world you're in. What I'd like to do over the next 20 minutes or so is to give you an overview of how we in Dubai have addressed the COVID pandemic. Very early on, our very first patient was actually a tourist from Wuhan who was detected to be positive at the very end of January of this year. Shortly after that, the government started taking measures to restrict spread of the virus. So in February, schools were closed and education then moved online. Mosques were closed as well, and they still remain closed. There were restrictions to movement placed. There were restrictions on flights. We brought back our nationals who were abroad at the time. And the government then formed a command and control center. And this is based at our university, the Mohammed bin Rashid University, that goes by the acronym MBRU. The chairman or the leader of this center is the vice chancellor of the university. And membership within this group includes representation from the public health sector, the private sector, health regulation, Dubai ambulance services, and various sections of the security services. So there's very broad representation within the command and control center. Also sitting in the center are representatives from the executive office. And this is the arm of government that actually oversees Dubai. And therefore, whatever work we do in the command and control center is aligned with the other branches of Dubai government. So Department of Economy, the Dubai Municipality, Dubai Police, and so on. Within the command center, we formed different work groups, and each work group had a defined role. And these groups included looking at testing, containment, what we initially called containment, supply chain, data and science. Recently, we added mental health. And finally, the stream that I'm responsible for, and that is treatment and healthcare capacity planning. Now, although these streams have their independent work to do, there is interconnection of the work of these streams. And the whole unit works as one coordinated whole rather than working in silos. And with regular meetings of the command and control center, we call it the CCC, we meet every other day at a minimum. And therefore, everybody is on the same page as to what is happening and what next steps need to be. So if we can look at the functioning of each individual group very briefly. Testing, we rely on the PCR. We do not use the rapid test or, at the moment, antibody testing. And the PCR has a turnaround time of about 16 to 24 hours. When we started this exercise, when the CCC was formed, there were about 3,100 tests performed per day in Dubai. And the testing group has managed to double this, to more than double this. So we perform over 6,000 tests per day. And the testing centers, of course, have increased around the city. And we even have drive-through testing centers. When someone is tested, the result goes into a database. And this database, of course, is electronic. And it's made specifically for COVID. It's called Hasana. And individuals who are tested, they're informed of their results. If they're negative, okay. But if they are positive, then they're referred to isolation or quarantine accordingly. So the containment team, we have hotels around the city. We use accommodation for as institutional isolation. And the hotels are attached to hospitals. So each hospital is responsible for a particular hotel. And they're responsible for providing medical care, medical staff, and nursing staff to the hotels so that the individuals who are in the hotels could continue to have medical care in case they deteriorate because of COVID, or in case they require care because of other coexisting conditions like diabetes, hypertension, and that sort of thing. Now, we haven't activated as yet home isolation, but we plan to do that very soon. We've developed an app, a contact tracing app, and once that is stable and implemented, we would then implement home isolation. In the meantime, the individuals who test positive, we've got a team not only to identify them, but to also identify their contacts and have the contacts tested. And this all works, like I said, in a very integrated manner. The third stream is the supply chain. And obviously, we need to have a constant supply of PPEs, constant supply of other equipment, ventilators, and so on, as required. Now, it has been a bit of a challenge sourcing some of these, particularly the ventilators, but finally we managed to do that. And we now have a good supply of ventilators. Equipment and material supplies are not only sourced internationally, but also locally. And we have companies that provide face masks, that provide hand sanitizers, and companies that do 3D printing, for instance, of face shields. And the supply stream ensures that there is a constant supply of these available to the healthcare community. The third stream is, or the fourth stream is data and science. And we combined these, but they actually work separately. The data stream, of course, they collect data, and we get data from different sources. Data with regards COVID and demographic data with regards COVID is collected by the Hasana system. We have in Dubai another integrated health system that collects data on beds, on patient numbers, and on equipment numbers, staffing, and that sort of thing. And that is a system that is present throughout Dubai, available to all the hospitals within the city. And they feed the data into this system. And that's done about 3 or 4 times a day. So we have not real-time, but near real-time information of patient numbers, bed availability, and that sort of thing. And this information is used by the bed management team that allocates patients throughout the city. So if, for instance, the ambulance service has a patient, they contact this bed management team, and they've got all of this information available in front of them, and they can very easily direct the ambulance to the nearest hospital that has availability of bed. The science stream now, what they do is they scour the journals to get updated information in terms of the disease, treatment, and that sort of thing. Obviously, COVID is a very, very rapidly evolving situation. And what this team does is that they get the latest information and present it to the group so that informed decisions can be made about whether to change our treatment strategy. Now, for instance, we've started plasma infusions, and we've got over 140 done already within the country. And it's a treatment that is at the moment experimental, but we are hopefully looking at the outcomes of this. So the science stream informs us as to the latest updates of the different aspects of COVID management. The mental health stream was one that we formed relatively recently. And this is a stream that is going to look at psychosocial aspects of different sectors, including healthcare workers, people who are in isolation, and the general community as a whole in the way they are affected by the restrictions brought out by the government. Finally, the treatment and healthcare capacity work group. We've got in the UAE a unified group that consists of the Federal Ministry of Health, as well as the representations from the health authorities around the country within the United Arab Emirates. And they formulate guidelines for management of COVID. And these, of course, are guidelines, and we try to work within them. Now, sometimes we need to adjust these guidelines, but part of our role is to look at these and implement them, make sure that they are implemented, make sure that they're functioning properly, and suggest adjustments to the guidelines wherever required. In terms of healthcare capacity, in Dubai, we've got traditionally a public healthcare service, and we've got a government healthcare service. And these tend, public or government and private healthcare. And these tend to work traditionally independently with very little cross-connection between them. But during this, this pandemic, what we've done in Dubai is we have combined public and private, and we've used the whole health system across Dubai for patient management. And this works pretty well. The team that I have, they include representation from the government hospitals, as well as the CEOs of the major private hospitals in the city. And with such good communication, it is, we find that we have easy, not movement of patients, but accommodation of patients into hospitals wherever required. One challenge we did face was one that has eased up a bit now, and that is the requirement for ICU beds and ventilators. Maybe about 3 weeks or a month ago, we had a very sudden rush of patients who required ventilation in short space of time. So patients would walk into the accident and emergency, for instance. He'd have a bit of difficulty breathing, but his saturations would be in the 60s and in the 80s. And these patients with silent hypoxia would collapse soon afterwards and require ventilation. And the coordination between the private and the government allowed us to manage this so that there was adequate accommodation of these patients to ICU units across the city. So at the moment, what we are doing is we are planning ahead for not the next phase, but I would say a continuing phase, because there is a realization, obviously, that COVID is going to be here with us for an indeterminate period of time. And so we're developing a strategy that we're calling Living with COVID. Within this strategy, we're including, of course, surge preparedness, because once we open up the city, more cases would come. We get an increased number of positives. Whether we'll have an increased number of patients that require hospitalization, we don't know that as yet. But we have to be prepared for the worst case scenario. So we're preparing for a surge, and remembering, of course, that coronaviruses, they tend to increase, at least their diseases increase during the winter months. So we're preparing for a possible surge at least until towards the end of the year, at a minimum. And at the same time, we are planning on extending healthcare services to deal with non-COVID situations. Patients with elective issues, or maybe even semi-emergency issues, and they've been putting off going to see the healthcare provider, mainly because of COVID. we want to make sure that these patients are adequately addressed so that there wouldn't be any delay or further delay in their management. So with that, I think that, that I've come to the end of the presentation, having given you an overview of what we've done and a very sort of quick idea as to how we are planning to go in the future. Thank you very much.
Thank you very much, Professor Kazim, for your very comprehensive description of the response to COVID in Dubai. While waiting for potential questions from the audience, I have a few for you. The first one, which is a situation that we have seen in a few countries, is the fact that there is the idea of mobilizing the hotels for, you know, the COVID patients that don't need really clinical care but needs to be isolated. Do you have any information on how, you know, is the system has been in place in terms of, you know, payment? Did the people have to pay for the hotel room? Was it taken care by the government as part of, because you offer free care to the Emiratis as that's social, the health coverage. So how was it in place? And the second question related to that, if you know, is how was it organized within the hotels? Do the staff of the hospital then came in to do the cleaning? Because considering that there is specific requirement with COVID patients that is closer to hospital rooms than the usual hotel cleaning, or on the contrary, the hotel staff was trained to be able to respond to the new requirements of cleaning requirements with hosting COVID patients?
Thank you, Eric. To answer your first question, the government foots the bill for these patients or individuals who are in hotel isolation. We don't ask them to do that. Your second question, I am not quite sure, to be honest. I think that there are cleaning companies that are contracted to do this, and they are trained in adequate PPEs and that sort of thing to be able to perform the role.
Okay, yes, so that's because it's a challenge has been very much around the health manpower, and there is a question around that. So how did you cope, you know, with the increased demand potentially of health workers, if there was one, and yeah, what is the situation in regard to that?
Yes, obviously in a in a pandemic, we need increased numbers of healthcare workers. We've been able to manage so far because obviously countries around the world have restrictions. So bringing in healthcare workers from abroad was not possible at one time. We did get approval from the government of India for us to bring nurses over. And we did bring a batch of nurses over to complement the nursing staff that we have. But so far, our complement has been adequate. Now, in preparation for another surge, we are considering bringing even more healthcare workers into the country on short contracted basis to cope with any possible surge.
Okay,
So
very interesting, very well and interesting response. Another question related to the, somehow you mentioned, you know, that you had to put some patient on hold, and you want really to make sure that non-COVID patients are treated now fully. Has there been a recorded drop of emergencies, whether there are all kinds of emergencies during the COVID crisis? And if it's the case, was it because of fear of people to get the COVID by going to the hospitals, or any other reason, or because they were locked down and there was less, for example, trauma, or any reason for emergencies?
Okay, thanks again for that question. It's an interesting one. I'll answer it in a slightly expanded fashion. Early on in the exercise, what we did was we stopped all elective surgery across the city to ensure availability of bed capacity, obviously. So following that, there were restrictions placed on movement. And even though there were these restrictions, people were allowed out if there was a medical emergency, if they had to go to the hospital or to a clinic for any reason. Patients who were on long-term care in hospitals, hospitals were delivering medications to them, to their homes. So the diabetics and the hypertensives and patients on long-term anti-rheumatic medication and so on, these were delivered to their homes, and this was free of charge. In addition to that, there were teleconsultation facilities. So some patients didn't need to leave their homes for medical attention. But what we did find is that patients were scared, like you said, to come to hospitals. And we try to reassure the public by having hospitals, even though they had COVID patients, there were regulations in place to separate so-called COVID from non-COVID areas and COVID care provision from non-COVID care provision. But in spite of that, you would hear anecdotal instances of where patients did not want to go to the hospital and they were delaying treatment. Now, obviously, if that was to continue for a long time, it could lead to quite a bit of morbidity and in some cases, perhaps mortality. So what we are doing at the moment is trying to identify hospitals that we would call clean hospitals that patients can go to for their care. And so that we would not be neglecting these patients who have non-COVID, perhaps long-standing issues that need to be addressed.
And so
did I answer your question?
Yeah, thank you. Yeah, this is a very comprehensive response. You mentioned clean hospitals. In relation to that, did you have a number of people, health workers that have been detected to have contracted the COVID? And have you in place a systematic approach to make sure that all the health workers are COVID-free, if we can say? And in relation to that, is it a debate about, doing a serology and delivering a so-called immune pass? As you may know, there is a big discussion about that.
Okay, yes, obviously we have healthcare workers who have tested positive. I think that was inevitable. But the interesting thing is that when we look at them, a number of them contracted from the community. Not all became positive because of exposure in hospitals, because of living conditions within the community. But the interesting thing is that those who became positive, we think from their hospital work, the majority of them were not those who were involved in intensive care, healthcare provision. They were those who were on the general wards. And I think that the ones who were in dealing with ICU setup, they took their extra precautions and not many of them became positive. More of them in the general wards became positive. Yes, there is a protocol in place for testing and ensuring that healthcare workers are COVID-free. Well, that's how we picked up the positives. Obviously, in the first place, they were asymptomatic. And to make sure that everyone is trained in the proper use of PPE. So, does that answer your question, Eric?
Yeah, very well. And is there a debate about, doing the serology to figure out if people have been exposed and potentially are therefore COVID protected, if it's the case? Because there is a lot of discussion about that.
Yes, that discussion is ongoing with us. We haven't implemented it as yet. We want to ensure that, in fact, it is something that is going to be not useful, but safe, because there are reports coming out from around the world that this so-called passport doesn't actually give you immunity. So we want to ensure that it is something that is safe for the community. before and if at all we implement it. So the discussions are still ongoing and there's no finalization as yet.
Okay, yeah, thank you very much. Other questions around, the situation that you described very well is mostly around Dubai. You talked about coordination, but we know UAE is two large megalopolis, Dubai and Abu Dhabi, but it's also a number of smaller towns that are under the authority of the Federal Ministry of Health. So is the situation similar? Are there quite important differences in the approaches? Anything you would want to give us to have a better insight of all the variability of situations within UAE?
Okay. The UAE, of course, the United Arab Emirates consists of 7 emirates, and Dubai is one of them. The capital is, of course, Abu Dhabi. Now, the situation in all the emirates are about the same. But they've addressed the situation perhaps slightly differently. We've addressed it in forming a centralized committee, and everything COVID related, and even sometimes not quite COVID related, but something that would impact healthcare provision to COVID patients and sometimes non-COVID patients, that has to be coordinated through the central committee, the CCC. So we are different in that we formed this central committee, but in the other emirates, there is also coordination of addressing the COVID response. Different, but still coordinated.
Okay, and is the situation in terms of exposure similar or quite different? That means you would expect that the smaller town perhaps don't have any COVID patients, or is it?
Oh no, they have COVID patients, obviously, but I think that it's roughly similar. Dubai has a sort of a concentration of its population, so it's bigger than the Dubai as a city is bigger than obviously the smaller emirates, but. I think that in terms of, if you were to look at proportion-wise, the experiences are about the same in terms of the disease.
Yeah, thank you very much. Let me acknowledge among our participants, Professor Ramirez, who is asking an important question in regard to the work we are also doing in IHF, is whether there are specific management leadership lessons in relation to what has been put in place that can inform and be further adopted in preparation for future related events.
Yes, I think that we learned a lot from this pandemic, and we're continuing to learn a lot. We've had very strong support from leadership. And the chairman of the CCC reports regularly to the leadership, and the leadership has also been in direct contact with the members of the CCC. So in addition to having coordination within the CCC in the way, functional coordination, there is also movement to the top as well as leadership direction down. So this governance structure works very well. So I think that is one lesson that can be taken away, and that is to ensure that that leadership is involved and strongly supports all the initiatives that are being done. Secondly, that whichever way it's done, that there is coordination within all the teams working so that the teams actually work as one coordinated unit. The third thing that we learned from this is that we've got to utilize government and private facilities as one coordinated combined unit. So Dubai Healthcare Service we looked upon it as one. Now that would mean obviously because the private sector, they rely on they've got different financial components as relate different from government. So what we've had to do was to get healthcare funding involved to ensure that there was continued funding for the private healthcare services. Now, obviously the funding could not be at the same level as pre-COVID times, but at least it was at a level that allowed them to continue to function until such time that we are able to, if you will, open up the city again so that we can have elective work once more continuing.
Okay, very, very interesting for the leadership. So somehow, if I can summarize, you have put in place a model in which you have a very effective combination between what we could call the horizontal leadership, which is mobilizing and coordinating, and the vertical leadership, which is more the one under a command and control. And usually it's opposed in leadership, and you have been able through this crisis to articulate it in a smooth and effective way. I think it's very interesting. For the private and public collaboration, I will ask a question in relation to your response. Dubai Health Authority has a very particular role because at the same time, it's a health service provider for the public sector, but it is also the regulatory authority for all the health service providers. So the fact that it is the regulator did it help a lot to make sure that the private sector was fully involved and didn't look, the potential public sector as a competitor, because at the end of the day, DHA is the boss of the whole system.
Yes, DHA or Dubai Health Authority has as one of its sectors healthcare regulation. But healthcare regulation works sort of not quite autonomous, but semi-autonomous from the healthcare provision side of the DHA. And what we did within this whole exercise is that we had the healthcare provision side with us, as well as the health regulator. And communication. There was constant communication between the government and the private healthcare sector. And my role as the leader of the team looking at healthcare capacity with membership from the main private hospitals meant that there was constant communication. They were always in touch and always informed as to what was happening. Even now that we're preparing our strategy for the future, I passed it by them before I take it to the Central Committee for ratification. So even though regulation is included within the DHA, they function semi-autonomous, and they're actually keen in having the healthcare sector remain afloat as much as possible.
So it's a very interesting institutional model that I think could inspire different countries for the way they organize their public sector. I have a question about the use of field hospitals. You had some in place?
Yes, I totally forgot to mention that. We've got 2 field hospitals at the moment. We've got one which has a capacity of 1,200 beds. And that hospital at the moment takes just mild cases. What we've done is we've categorized COVID patients into, of course, they're the asymptomatic positives, and then they're the mild, moderate, and severe, depending upon their clinical signs and symptoms. So that one field hospital takes just mild cases. We have another field hospital that is within the city in a convention center, and that has potential expansion to 3,000 beds. We're opening that in phases. So at the moment, we've opened 800 beds, and we've actually gassed these 800 beds. I shouldn't say gas, at least we've put in facilities for medical gases and suction for 800 beds, and as well as electrical connections, so that we can use these 800 beds even as ICU beds if required. So it is, if you will, an upscaled field hospital. We've not utilized the ICU facilities. We didn't need them as yet, but they are available if required. And we ensured that there were enough electrical points, so not only for the ventilators, but for the monitors, the syringe pumps, and so on, that are required for ICU setting. Now, we have found that the field hospital has been instrumental in this whole exercise, because what we've been able to do was decompress hospitals so that they can take care of more severe cases. At one point in time, we had patients in ICU who were also requiring dialysis because they went into renal failure, and some patients even requiring ECMO, extracorporeal membrane oxygenation. And these services are located obviously in the tertiary hospitals. So by using the field hospital to decompress the hospital, we were able then to get the hospitals, the main hospitals, to focus on providing these specialist care for patients as required.
So if we look a little forward, and also I'll ask one question along with that, is that do you think that this is going to be, the field hospital should be really a recommendation as part of accepting to live with COVID, in the sense that it gives you really a quick surge capacity, and therefore you will need to maintain them, even though you are moving perhaps in the next month in a situation where all the others hospital can cope with the patients? And is it also a way perhaps to separate the patients so that you can have more dedicated COVID hospitals? Because is it something that you would be moving towards to make it easier? We were talking about patients that are fearful to come to the hospital because of COVID, to have not only dedicated wards, but dedicated hospitals which are totally COVID-free, and hospitals that are more COVID dedicated.
Yes, I think that you've articulated that accurately. We would need to keep the field hospital for a while, because they would be instrumental in surge capacity. When that surge, if at all it comes, we don't know when. So it means that at least until the end of the year, or probably 1 year from now, we're going to require the field hospital. And even if we don't have a surge, we can use the field hospital as the COVID hospital, where we could move all COVID patients into the field hospital, depending upon the number, obviously. And so we can free up the hospitals so they can go back functioning as normally.
Yeah, and you also have the expo, the World Expo that was postponed. And therefore, I guess that it's part also of the plan, because if the travel resume and you have the visitors for the expo in 2021 in March, starting March, April, I guess after the Ramadan, it means that you will have also need of extra capacity. So I guess you will rely also on these field hospitals.
Yes, yes.
So for the healthcare workers, do you have to retain some of them you talked about increasing the number of them, agreement with India. What are the plans there? Do you have plans to retain some of them after the epidemics to be also in the transformation for the next normal? What are the plans?
Well, there are no firm plans about that at the moment, Eric. I think that it would depend upon the individual healthcare worker, as well as the organization that they belong to, whether they will remain or not. In terms of requirement, what we've done so far is that because of stopping electives, a number of clinics and day surgery centers, their work fell dramatically. So we put out requests to the healthcare workers in these facilities for them to come and work with us temporarily. And a number have come to work with us temporarily. And that increased our capacity, our staffing capacity, to allow us to deal with COVID patients. Now, when everything goes back to functioning so-called normally or adjusted normally, we would lose these healthcare workers. And at that point in time, or just before that point in time, we'll have to make a decision as to whether we would require to bring more workers in or not. Now, these could be some or all of those we've contracted over from India. It could be others. But certainly that's something that we would need to look at when things begin to go to baseline.
I know it takes some time for education, but is the crisis also an opportunity to have different plans for increasing the national capacity of nursing? That means to be able to have more people trained within UAE in nursing schools?
Yes. The answer to that is yes. We don't have the plan as yet laid out clearly, but that's one of the lessons that we've learned from this exercise. And that is that we've got to have more in-house capacity. And that would include nurses and doctors as well. But also, we have had along the way to repurpose healthcare workers. So we would have had, for instance, specialists, urologists, rheumatologists having to do internal medicine work and look after COVID patients. So this now would impact regulation. So we have to look beyond this now and see how we can adjust the healthcare service in terms of not only numbers, but in terms of functionality, in terms of continuing education, and things like that, so that we would be able to have a healthcare workforce that can deal with the new normal.
Yeah, a country like UAE, I guess, is mostly importing all the protective, personal protective equipment, and there has been quite a lot of debate in countries to become safe, sustainable, and to produce themselves as a vital good, the PPEs. Is it something that you are discussing within UAE or GCC countries, for example, to make sure that you don't rely on supply chain and imports in case of other crises?
Yes, I can speak for Dubai, and that is that there are different organizations within the city that are producing different things. I had mentioned the sanitizers, the face masks, and PPE. Now there's another group that's actually looking at new materials for PPE and the reuse of PPE. So these are things that are other lessons that we've learned, and we would try to be as self-sustaining as possible. Whether we would become self-sustaining, that we need to wait and see. But certainly there are steps in the direction to become self-sustaining and not rely from import from outside of the country.
Another question that is coming back to the previous response in terms of scaling up the capacity of nursing capacity. Are you also looking with the regulation at revising the relicensing for nurses that are there but have not practiced for a while, you know, and would want to come back to practice, and especially potentially expats that are living in Dubai?
Yes. Now, obviously, regulation, they've got their own rules. And in terms of nurses, be they, I mean, well, expats or nationals doesn't really matter. But in terms of those healthcare providers who haven't worked for a while and now want to work, we've got different sort of, I wouldn't say upscaling, but I suppose you can use the same word, or reskilling them so that they would be reasonably competent to rejoin the workforce. Now, obviously, that's another issue that we would have to address when we come to looking at our strategy of living with COVID. how are we going to provide continuing education, and what are we going to provide, and what is required for a so-called future workforce for the city.
Perhaps a last question before wrapping up. You mentioned a number of stakeholders that you have involved quite early and on through the whole stage of mobilization. I didn't perhaps hear about the patient organizations. And as we know, especially for the chronic conditions, the patient organizations play an important role to be supportive for the chronic patients. Are they part of the game? And if they are, how are they involved?
No, they are not part of the game. There are these organizations available. We have not had we've not had their involvement, and their involvement isn't something major at the moment within the city.
Okay.
So the answer to that is no, really.
Okay. So perhaps let me give some takeaway messages, if I can, from this very rich presentation and our Q&A session. So I would just start with saying that, from the Dubai experience, we see that it's very important to be early in the response, because when you gave the timeline, we saw that you responded very early in the epidemics. The second lesson is that it's very important at the early stage to have the broadest possible involvement of all the stakeholders that have to deal with all the dimensions that will be involved with COVID and far beyond the clinical and the medical aspect. The third one is that it is also quite important to have this rapid increase of the clinical response, but it has to be also supported by advanced information system for it to be really effective. Full coordination is really also very important at all stages when it starts to be at play, where the response is in place, to go on and to make sure it's sustained and it fully delivers what it is expecting to do. The coordination is a major driver for that. It's also very important to have in place a way to monitor, especially when you face a new threat, a new disease, how the potential clinical responses, should be evolving in terms of treatment protocols and things like that, so that the best guidelines and practices can be very quickly disseminated and adopted for the benefit of the patient. And last but not least is that facing a crisis is one step, but when we realize that we have to face a threat that is not ending after the crisis, it means it's a transformation that has to be put in place, and it's very important to start early in preparing this transformation. Professor Kazim, any last comments and thoughts before we end this webinar? And I really thank you for your very interesting, comprehensive information about what has happened in Dubai.
No final thoughts. I think that you've articulated everything pretty well, Eric. The only thing perhaps is we also focused on testing to identify affected individuals so they can be dealt with accordingly. And also very important to plan ahead so that you're not sort of caught unawares with the next wave of something and you're not prepared for it. So thank you very much.
Thank you very much. Patricia, the floor is yours for the final of this webinar.
Thank you very much, Eric. Thank you very much, Professor Kazim, for that very comprehensive and insightful discussion. We really appreciate all the information that you shared with us today. We still have a few webinars signed up this month and in June. The schedule is now posted on your screen, and we hope you can join them too. If you would like to register, just go to www.ihf-fih.org/webinars. On Tuesday, Professor Anupam Sibal of Apollo Hospitals, the largest hospital network in India, will talk about Project Kavach, the integrated program they developed to respond to the needs of the patients and their community. He will also share the other initiatives they have implemented for community awareness. So we hope you can join us there. In the meantime, please stay safe and healthy. Together, we will overcome this crisis. Dr. Kazim, thank you again for joining us today, for your time. To everyone, thank you so much for participating in this webinar.
Thank you. Bye-bye, everyone.
Thank
Have
you,
a great day,
everyone.
everyone.
Goodbye.